We will study today about the diabetic retinopathy, pathogenesis, classification, and the risk factors. The pathogenesis of the diabetic retinopathy is underlined, is underscored from the pre-existing diabetes which causes chronic hyperglycemia, which further causes the metabolic response. The metabolic response is responsible for the chronic inflammation, the microvascular damage leading to the endothelial damage to the retinal capillaries, the capillary occlusion, and the leukostasis, which further lead to ischemia, and the metabolic response can itself lead to ischemia too. Because of all these factors, that is inflammation, the vascular damage, and the ischemia, there is increase in production of VEGF factors, that is the vascular endothelial growth factors, which lead to neovascularization and the breakdown of the blood-retinal barrier, which further leads to the increase in vascular diffusion, which further is responsible for the diabetic retinopathy and the macular edema. The lesions in the vessels wall. There is alteration in the endothelium and the basement membrane because of the metabolic response we had seen. Because of this, there is alteration in the tight junctions between the cells, increase in the exudates, and the breakdown of the blood-retinal barrier, which is responsible for the edema and exudates. Also, because of the alterations, there is bulging of the capillary walls, which lead to dilated tortuous vessels, microvascular edemas, and microaneurysms, which further lead to edema or ischemia. Ischemia further leads to VEGF production. The pathogenesis of neovascular capillary occlusion can be tracked down to the changes in the blood flow, which are increased flow, increased viscosity, and increased hematocrit in the diabetic patient, which leads to the retinal hypoxia. Changes in the erythrocytes lead to increased aggregation of the erythrocytes and decreased deformability, leading either to the retinal hypoxia or the capillary occlusions. The changes in the plasma of the patient leads to hypercoagulation and decreased fibrinolysis lysis, which lead to the capillary occlusion, and the changes in the blood flow because of the increased adhesiveness and increased aggregation of the platelets lead to capillary occlusions in the diabetic patients. Also, there was found an increase in the von Willebrand factor, increased thromboxane, and decreased prostaglandins in the diabetic patients. Because of the capillary occlusion, there is a further ischemia, and this ischemia combined with retinal hypoxia leads to increased VEGF production, which further leads to neovascularization either of the iris or the retina, that is the neovascularization elsewhere, or the new NVD, that is the neovascularization disk. The further complication of NVI can be the vascular glaucoma, and the neovascularization elsewhere and the NVD can be the hemorrhages, vitreoretinal diausis, and the detachments. The classification systems. Diabetic retinopathy has been classified historically so that the various scientists can talk in a common language, and the doctors can also present their cases synchronously. Historically, the initial classification schemes for the diabetic retinopathy were developed to facilitate the communication among the researchers. In 1968, the U.S. Public Health Service held a symposium at the Early House in Warrington, PA, to develop a classification system for the diabetic retinopathy. The Early House classification system used 5 standard photographic fields. That is, the field 2 was centered on the foveola, fields 4 and 5 were just above and below the foveola respectively, fields 1 and 3 were just nasal and temporal to the foveola. The retina in Early House classification. The fundus lesions, hemorrhages, microaneurysms, lipid, neovascularization, etc. were classified into one of the 3 categories as either absent, mild to moderate, or severe. However, with only the 3 levels of severity, graders use the Early House classification who often find it difficult to reach the consensus. This system therefore fell short in its ability to communicate with the consistency between the researchers. The reason of the failure of this classification was that it did not define enough distinction between the mild to moderate lesions and severe lesions. The result was that most of the lesions were lumped into the mild to the moderate category. In the lumpers versus the splitters distinction, there was not enough splitting. Therefore, after the earlier house classification, there came the diabetic retinopathy study, the DRS study, which subsequently created a modified earlier Houseway classification system with a greater degree of splitting. Two additional photographic fields were analyzed, that is the field 6 supranasal and the field 7 inferonasal to the optic nerve head. In addition, more gradations of severity for the individual components were added. The primary question asked by this study was whether the photocoagulation helped to prevent severe visual loss from the PDR or not. Eligible patients had either the PDR or the severe NPDR. This is a fundus diagram showing the various fields used in the LA house classification, like field 2. The standard field 2 was centered around the fovea. 4 and 5 were just immediately above and below it, and 3 and 1 were temporal and nasal to the fovea, and 6 and 7 were inferonasal and supranasal to the disc. The GRS definition of the severe NPDR had any three of the following characteristics, that is, the soft exudates definitely present in more than two photographic fields 4 to 7, edema definitely present in more than two of the photographic fields 4 to 7, venous bleeding definitely present in more than two of the photographic fields 4 to 7, hemorrhages or microaneurysms more than equal to severe, that is the standard photograph 2A, or more than one of the photographic fields 4 to 7, or the edema more than standard photo 8A in more than two of the photographic fields 4 to 7 and definitely present in the remaining two fields. Then came the ETDRS grading. ETDRS graded the disease severity levels into mild, moderate, severe, early PDR and high-risk PDR. Early NPDR contained at least one microaneurysm and definition did not meet the moderate or the severe NPDR definitions. Moderate NPDR had hemorrhages or microaneurysms more than equal to standard photograph 2A, or the soft exudates, venous bleeding or the edemas definitely present and definition not met by the severe NPDR or higher categories. Severe NPDR had cotton wool spots, venous bleeding, edemas all definitely present in at least two of the fields 4 through 7, or two of the preceding three legends present in at least two of the fields 4 through 7, and hemorrhages and microaneurysms present in these four fields more than equal to standard 4 to 2A in at least one of them, or the edema abnormalities present in each of the fields 4 through 7 and more than equal to standard photograph 8 in at least two of them, and the definition not met for the early PDR or the higher grades. Early PDR had new vessels and definition was not met by the high-risk PDR, and high-risk PDR stands for new vessels or on or within the one disc diameter of the optic disc, more than standard photograph 10A, with or without victrous or preretinal hemorrhage, or the victrous or the preretinal hemorrhage which is accompanied by the new vessels with either NVD less than standard photograph 10A or NVE more than 1/4 of the disc area. Then we can also classify the diabetic macular edema through the ETDRS classification into two categories as either diabetic macular edema apparently absent or apparently present. In the apparently present, there is a thickening of the retina within one disc diameter of the center of the macula and or hard exudates more than standard photograph 3 in the standard 30-degree photograph field centered on the macula, with some hard exudates within one disc diameter of the center of the macula. Then they also defined the clinical significant retinal edema as retinal thickening at or within 500 micrometer of the center of the macula, or the hard exudates at or within 500 micrometer of the center of macula if associated with the thickening of the adjacent retina and oblique or a zone or zones of retinal thickening, one disc area in size, at least part of which was within one disc diameter of the center. This shows the various definitions of the clinical significant macular edema. This is the standard photograph 2A, which shows the hemorrhages, which is considered as the standard for the hemorrhages or the microaneurysms in eyes with severe NPDR in all the four mid-peripheral quadrants. This is the standard photograph 4, severe standard for hard exudates. This is the standard photograph 6A. This is the less severe of the two standards for the venous bleeding. This is the more severe venous bleeding, the standard 6B photograph. This is the standard photograph 8A, which shows the moderate edemas and which are present in the severe NPDR and at least one quadrant. High risk PDR. This is the photograph 10A, which shows new vessels on or within one disc diameter of the optic disc, equaling or exceeding standard photograph 10A about 1/4 to 1/3 of the disc area with or without vitreous or preretinal hemorrhages. This shows the standard photograph 13, and this is used to define the lower boundary of the grade 3 preretinal hemorrhage. Then the classification which we use today is the International Clinical Disease Severity Scale for the Diabetic Retinopathy. It is based upon the findings of the Wisconsin epidemiologic study of the diabetic retinopathy, Vascular, and the ETDRS. This new classification is simple to use, easy to remember, and based on the scientific evidence. It classifies the disease with the severity level into no apparent retinopathy, which shows no abnormalities on the dilated ophthalmoscopy, mild NPDR as being microaneurysms only, moderate NPDR as more than just microaneurysms but less than severe NPDR. The severe NPDR had US definition and international definition. The international definition stated that severe NPDR is any of the following and no signs of proliferative retinopathy, that is, more than 20 intraretinal hemorrhages in each of the four quadrants, definitive venous bleeding in 2 or more quadrants, and prominent edema in 1 or more quadrants. It classified PDR as one or both of the following criteria, that is, neovascularization, vitreous or preretinal hemorrhage. It classified the diabetic macular edema as being apparently present and or being apparently absent. The apparently present showed some apparent retinal thickening or hard exudate in the posterior pole. And if the diabetic macular edema is present, it can be categorized as below, as mild diabetic macular edema, moderate and severe. Mild is some retinal thickening or hard exudate in the posterior pole but distinct from the center of the macula. Moderate is approaching the center, and the severe is involving the center of the macula. Hard exudates are a sign of current or the previous macular edema. It is believed. This is believed. British classification and proposed international classification in 2003, a national screening program for the diabetic eye disease in the UK was developed. Despite this classification uses different nomenclature, the meaning of them is practically the same in this grading system. No retinopathy is graded as RO, background as R1, pre-proliferative as R2, which includes the moderate NPDR and the severe NPDR, the proliferative as R3, and the maculopathy and photocoagulation are classified in either being absent, that is M1 PO, or present, that is M1 P1. Diabetic macular edema. With this we have come to the end of the pathogenesis and the classification of diabetic retinopathy.